To those who are here, thank you very much for joining us. We are, I am the president of Nepal Social Impact Association, and tonight we have another wonderful webinar. I've got quite a series now of webinars, and this one in particular I'm really excited about because it's close to my heart, trauma-informed practice. And I will remind you that all of the reason that I'm here and the reason why I think perhaps a lot of you are here, and certainly my dear friend Joy is here, is to support the Nepal Social Impact Association, which was formed as a result of the work that we do through Torrens via the New Colombo grants that we have been given that take students to have a cultural experience. And in this case, we take you to Nepal, and most of you are aware of that or perhaps have even been, and you might recognize some of those. There's some of my photos anyway. There's me in the middle with Chloe, who's on tonight's call, and Quill, who probably is also on tonight's call, and the Annapurna's in the background, which is one of my favorite shots. For those of you who don't know me, I'm a nat, I'm a counsellor. I've been in clinical practice for 30 years now as a naturopath and counsellor, a naturopath and nutritionist, and I've added counselling along the way. And great memories, Chloe. And I'm also a lecturer at Torrens, and I'm absolutely thrilled to be here and introduce you to my dear friend and colleague. Joy is a psychotherapist. She's a playwright. And facilitator. She has degrees in dramatic art, psychology, child adolescent psychotherapy. And she works with psychodrama, immersive role play, and forum theatre, which you may not be aware of, but they're ways that she works with. I've got here that she helps with understanding in social systems. Her work spans an extraordinary array of things, from everything from NRL clubs to universities to schools, including programs on respectful relationships, sexual assault and substances. She also has a private practice, a psychotherapy practice in Crow's Nest, and she's been in practice for 30 years. I've known her for that long. And she's also a senior facilitator at the Plan McLean Centre at the University of Sydney. And they specialise in working with complex communication in healthcare settings. So that's really brilliant for us tonight. She's passionate about all kinds of things. She's a committed foodie, I know that. And she's really interested in having conversations with people that, to give them real agency and support their change. And it just makes it a great fit for us tonight. And I'm so thrilled to introduce you and welcome my dear friend and colleague Joy to be with us tonight. And we're going to take turns with the talking stick between us. That's, I don't know, do you want to add anything? Have you done anything else remarkable that I've left off?
Oh, no, absolutely not. I think that's more than enough. Thank you. This is where I am going to butt in and talk to you all about why our protocols for tonight are actually cameras on, please. And the reason that when Sue asked me to do this, I was like, yeah, absolutely. The thing about trauma is that, thank you for those of you who are switching on. The thing about trauma is it just has a sneaky way of appearing out of the blue, and trying to create a psychologically safe space online is an incredibly difficult thing to do. If I can't see your faces, at least, it's even more difficult for me to be able to monitor what's actually happening. Having said that, you're all really rather tiny squares, so I will also remind you that certainly from my point of view, there are things that Sue and I can do to be mindful of psychological safety. However, your psychological safety is your responsibility. If the webinar is going somewhere that is making you feel uncomfortable, if you are being triggered in any way, please feel free to switch off your camera and disconnect yourself from the audio and just take a moment to gather yourself, find ways to regulate yourself. And I will talk to that quite a lot later. Also, if you do, obviously, it's 7 o'clock in the evening. I'm quite sure that there are all sorts of things going on in your lives beyond this webinar. If for any reason you do need to leave or just to take some time out, if there's a child that needs assistance or anything like that, please feel free to switch off your camera. But can you just leave us a little message in the chat so that we know that you're going to look after someone else as opposed to needing to be looked after by one of us. Once again, obviously I've said that I need to see your faces. Nonverbal communication is responsible for kind of, like 80%, 85% of what goes on in terms of our human messaging. So really important to actually give that the nod.
And I'll just jump in. Sunenza, she's driving a car, so please, that's paramount. And you're welcome to listen. And perhaps if you stop at some point, not at the lights or anything, but once you get out, if you put your camera on, that would be most appreciated.
Right. Thank you.
Yeah.
Over to you, Sue. I've done my bit.
Yes, I know I'm changing the slides tonight, so that's do you want to have a chat about that? What we're going to cover?
Sure, I can do that.
Do
you want to do that?
No, well, I think it's fairly self-explanatory, and maybe we don't need to spend because we've got quite a few things we want to get through. So hopefully we'll tell you about what trauma is and what it isn't and when to recognize it. I think most of us online here are dealing directly with trauma is out of our scope, and it's really important to know what our scope is and when we refer, and we'll certainly be touching on that at the end. And I just wanted to first up outline it, and I've got some references and research papers that you can read. So I don't want to spend an awful lot of time on this because you can read about it. What I'm really interested in is being in the room with Joy and listening to her experience and working with us. But it's just worth noting that trauma is far more common than we realize, that almost half of adults have at least one traumatic event. So that if you are working in clinical practice as any healthcare provider, you will have people who have had a traumatic background. How that plays out for you in the session or perhaps in your work with them is maybe what we're really going to focus on tonight. And it isn't just one thing. Yes, it does include physical and sexual assault. It is serious accidents, natural disasters, and exposures to violence and even war. But it's also chronic stresses that will trigger this. So the chronic stress that overlies our Western world, I don't think it's world. I think I should leave the Western out of it. That everybody has work pressures, we're caregiving, we've got financial strains, particularly at the moment, and these all can add up and put people in a very vulnerable place, such that on top of the traumatic issues that they may have that are stored in every single cell in their body. And I didn't really go into how we store trauma, although that is a fascinating thing. And there's a lot of work around somatic psychotherapy and storing trauma in the body and how to access trauma in a safe way using body work, but that's whole nother ball game. Traumas that carry a higher risk are people who have experienced childhood abuse, perhaps violence of some kind with a partner There may be betrayal trauma, as we've looked at here, so difficulties with trust and attachment and identity, and that can come from very early on. Attachment theory is I particularly am interested in that, and it is looking at how we attach onto the primary caregiver in our life. So we're pre-verbal at that stage. And then, of course, mass trauma, which hopefully we don't experience so much in this country. However, many of us have come from different places, and that certainly is a part of the story. I haven't put in there either intergenerational trauma, which I think is an enormous subject on its own. I mean, this is a pretty big subject to tackle, to be quite frank. And I don't, but intergenerational trauma is incredibly prevalent as well, so that it may not be that you've had a traumatic event in your life or your patient has had the trauma, but their parents or their grandparents or their great-grandparents may well have. And that is sometimes not even apparent. And yet that thinking has been passed down through families. So vulnerability is not equally distributed. We've got refugees and displaced persons, and that is a growing number in this world. People in low-income communities are particularly at risk, as are children and adolescents. The less power they have in a relationship, the more vulnerable they are going to be. Women are far more likely than men still to experience interpersonal trauma. And as I said, the socioeconomics are often, and the minorities are often at greater risks. You may well, I just threw that in because I could. It's a Calgary chart looking at trauma and how it manifests. I didn't do any slides, although I could have gone into, I was very close to doing the neurobiology of trauma. And I just thought, again, that's such a huge topic. I won't try and tackle that because I think that's just overwhelming. And that's also just data that you can read if you are actually interested in how our HPA access, really how our fear will trigger our hypothalamus and our amygdala, and then the cascade of events that come after that. And in the nanosecond that we're experiencing something that perhaps for a lot of people is not necessarily traumatic. You might hear, a car backfire and think, oh yeah, that's a car. Someone else who's had a traumatic event will hear that and think they're right back exactly in that place where they experienced the trauma, and that's the problem, that they are hypersensitive and that they can be triggered by seemingly ordinary things. And that may well happen to us whilst we're dealing with them in clinical practice. And so with all of that said, I'm going to hand the talking stick back to Joy.
Thanks, Sue.
And please add anything you want to there.
Yeah, those slides were so dense, and I think first and foremost, one of the most important things for us to remember is that trauma is a response. Trauma is not actually an event. So an event happens and we will respond to it. Sue and I might be caught in the same bushfire. What happens for Sue is she's able to wet some towels and put them down next to all her doors. I'm not able to do that. Okay. Both of our houses burned down. The probability of me being traumatized by the event, so my response is one of trauma, and Sue not having a trauma response is quite high. And the difference is the fact that Sue had agency. Sue, even though her house burnt down, she could look at the event and know that she had a useful response. Okay, so quite often that can be the difference. The difference between actually trauma developing or our trauma response being embedded in our brains or not is really correlated with how much agency we felt we had. And one of, that's one of the reasons that things like domestic violence and sexual assault have such high levels, not only of type 1 trauma, and I'll talk about that a little bit later, but actually type 2 trauma, because it becomes so complex, because in those instances, people feel so powerless. There is a true story, which I do have permission to tell, which is about a nun, and she was raped. And while she was being raped, what she did was she told the rapist that he was doing it wrong, and that really, if he was going to get this right, he should do things differently. And she started instructing him what to do. He ran away. So at the end of the day, the nun was still raped. However, because she had held on to her agency, she did not produce any symptoms of PTSD at all. Okay, and that is clearly just because she felt like she had agency. So, and that is not always, it's not always possible for us to lean into our agency when we are frightened. And that has to do with the way our brains work. Yeah, what happens when we go into fight or flight? As Sue mentioned, our amygdala, our hypothalamus, they're geared to look for danger. When they see something that feels dangerous, okay, and I'm sure you all know about fight or flight, the blood goes to your large muscles, your digestion closes down, your heart beats faster, you're ready to do something. Most importantly, your prefrontal cortex goes offline. And because your prefrontal cortex is not there, there are all sorts of things that happen to the way the memories are laid down. So when people sit in a traumatic response, it's actually memories that have lost their link to the actual event. So we've got all these memories running around and causing havoc, first and foremost, and our amygdala is firing because we didn't manage. If we were in an event where after the event we were not able to stabilize to our base level, the possibility of us having a repeated trauma response is very high. Okay, so sorry, I'm just a little hot here. So when we're dealing with trauma, with people who are in a trauma state, one of the first things we want to do is try and help them get their prefrontal cortex back online. Okay, how do we how do we actually realign them and get them back into their bodies? If you're looking at the slide, what do we see? How does trauma show up? Chronic illness, obviously, in your practices, in my imagination, and Sue, you can most probably talk to. Do you notice a pattern of specific chronic illnesses?
What I sometimes see, and they can manifest as anything, often digestive disorders or digestive issues, headaches, quite mild things really by comparison, but they are difficult to resolve.
Yeah.
They keep happening because the trigger's still there. So when you try things and they don't work and you're thinking, damn, that usually worked for everyone else, doesn't work for this person, and you try thing after thing after thing, that's when I start asking more questions, I think.
Yeah, absolutely. Emotional dysregulation, people who, and look, for me, emotional dysregulation is a really tricky thing because not all people who are emotionally dysregulated are so because of trauma, but many people who are dysregulated are so. So it's not there. There is not a firm causal link. You can't say all dysregulation is caused by trauma. You can say that it is possible that this dysregulation comes from trauma. Disassociation, that is quite often trauma, most often trauma, because actually I want to leave my body. Dissociation talks to what happens so I don't know, I'm running through the savannah and there's a lion chasing me, because of course this is what I do every weekend, and I'm running and running and running, and I get to the point where I realize that I'm not going to be able to outrun the lion. This lion is going to catch me and he's going to eat me. Actually she, because it's the lionesses that actually do the hunting. What happens to my system then is I shut down. So my body gets ready to die. My focus becomes very narrow. I become quite limp. I might become dissociated, because it's like there is nothing here for me to do other than die. And my brain says the easiest way to die, when you know it's inevitable, is just to shut down, so that so that it's not so bad. But that's something that our bodies do. We have no, once again, it's our amygdala and our brainstem that's in control. And so quite often when we see people dissociating, it is they've gone so far into the trauma response that they've actually got to that point where it's like, okay, I'm going to die, so I might as well just collapse. When we look, was there something there, Sue?
No.
No. So when we look at the impact, what actually happens for someone when they're having a trauma response, what do we see? We're seeing intrusions. So intrusions are thoughts that come unbidden to our brains, and we may not even know that we have been triggered. Just suddenly there is a thought. That thought might be a flashback, it might be a memory, it might be it might be a dream. I'm just thinking, I had my final client of the day today. She's an 18-year-old who is remarkably traumatized at the moment, and we were talking about her dreams, and she's really angry that she's dreaming. And she's really angry because there's something in her system that's trying to get her attention, and she's not that happy about it. Anyway, we'll keep working with that one. What else do we see? We also see avoidance. We see, so avoidance is, I can't, people that can't get out of bed, people that can't leave the house, or avoidance of certain foods, avoidance of listening to a certain radio station, or avoidance can take it has many guises. Dysregulation, so I just have no control of what my emotions do. And then negative alterations of cognition and mood. So those negative alterations, what we mean by that is, once you have experienced trauma, what can happen is that you have persistent negative thinking. Okay, so that's the negative alteration. And that might have to do with how you think about yourself. It might have to do with how you think about others and the world. Quite often this negative thinking will fuel anxiety, depression, social withdrawal. So it really does change everything I thought I knew to be true before my experience has suddenly shifted. And so trying to come to terms with a world that for many people has no feeling of safety left, can be really tricky. What that can also look like is, and this is stuff that you might pick up in your clinical settings, people who catastrophize. Oh, you say one thing and before you know it, it is the end of the world. They're quite sure it's the end of the world. Personalization, like anything that's happened. I don't know if you've had, patients who, I don't know, they forgot to take their supplement and you're like, oh, well, and they're like, oh, no, I'm a bad person. They're so ready just to cut themselves down, to make everything that's happened their fault. Overgeneralization, this has happened. And so because I read, this is one of my favorites. I Googled something and it said, and it said that 2% of people have this response to this particular supplement. So of course, all supplements are bad and I'm going to die. Okay. And black and white thinking. So for people who are caught in these impacts of trauma, it's, life becomes quite hellish. For those people who actually are suffering from complex trauma, so, and this, what we know is, once again, people who have experienced sexual violence, people who have experienced domestic violence, people who've experienced childhood abuse, particularly in that realm. Those are the experiences that are most likely to be correlated with complex trauma. And what complex trauma looks like is all those things that I listed earlier, the intrusions and the avoidance, and the dysregulation, and negative, negative alterations to cognition and mood, plus hypoarousal. So rather than the dysregulation that we might see, okay, hypoarousal looks like those people that come in with really flat affect. They might shuffle. It's almost like there is no emotion at all. That when you're looking at that, you're looking at hypoarousal. The affect regulation becomes really difficult. So trying to get them to, I mean, this is one of the things that for me as a psychotherapist is it's really difficult to work with when you have someone who is just so flat. It's like there's nothing coming back. It's like there's nothing in the room. Like how do I work with this? Luckily, I mean, I would imagine, I don't know, Sue, I think your insight into this is probably really useful. I don't know if you've had patients that have presented like this, but I would imagine that in your world, you've got things that you can offer. You've actually got stuff that you can offer them. My world is a little different. I don't know. What's your response to hypoarousal in your clinic?
I think we can support them to a point, but just as I said earlier, if it's got a different underlying driver than the one we're trying to work with the supplement or the herb or even the nutrition, it's not going to go away. And I think that sometimes we try harder and harder and get more and more frustrated. And I think that then comes out, which of course is another layer to a person who's already underwhelmed or overwhelmed or traumatized. And then now they're disappointing us. And we get into a whole spin with them not feeling like they're doing the right thing by us and they're failing, and it's almost like a spiral downwards. And if we're not aware of who we've got in the room, we can join in that spiral, which is not helpful for anyone.
Oh yes, oh yes. Joining the spiral is a nightmare. Um, Okay, so traditional approaches. So here's the thing that certainly as somebody who's been in practice for 30 years is, one of those things where you really believe that you've been doing the right thing because that's what you learned. And I don't know if any of you have been out in your practices for long enough, but when I first trained, absolutely, we were going to talk everybody out of trauma. These days, more and more, what we're seeing is most of the talking therapies just re-traumatize everyone, because every time you get to tell the story, basically what you're doing is you're making your amygdala fire. You're actually inviting your prefrontal cortex to take a very long holiday, and so you stay stuck in the trauma. And certainly, when I think retrospectively, and I think of some clients who, for months, one of them probably for at least a year, the regurgitative story. And it's like, how do we get out of this loop? And yeah, so what we know now is that actually, because we now know that trauma is stored in the body and the nervous system, what we know is that cognitive approaches are not enough. I'm not saying that we don't talk about it at all, but I am saying that there are things that we can do that are probably going to be far more effective for the people that are experiencing trauma. And a lot of that, is based in the in my world, the really trauma-informed care is rooted in mindfulness. It's rooted in how do I bring you into the present moment? How do I help you actually ground yourself into your body? How do we support your body to actually manage this state that you're in? And I would imagine that so that that kind of opens doors for you folk. And it is why I do believe that multidisciplinary approaches across just about everything are always going to be the most useful. They're always going to be more useful than just saying, well, it's a bit like certainly in psychotherapy land, people get very attached to their modalities. My modality is better than your modality. Actually, much like I'm imagining your world, for some people, maybe it's herbs. For some people, maybe it's supplements. I don't know. Sue, I'm actually talking out of my scope, so I'm going to hand
No, you're
to
not.
you.
And I think, that's how you and I have become so tight over the years, because we've worked together with patients, and I've done the physiological and you've done the psychological. And
Yeah.
I think what we've discovered in our own little world is that the people that do both can move forward more easily, or perhaps more thoroughly. I don't know if that's the right way.
Yeah.
But and from my little pracky brain as a gnat or a nut, I'm sitting here thinking it's all the biochemistry. Yes, it's the neurotransmitters. Yes, it's the inflammation. Yes, it's got to be the hormones. And that's true, but it's also not going to be as complete, or it's not going to resolve perhaps, if we don't address the driver, which of course is out of our scope, being in this case trauma, or any psychological, whether it's grief or whether it's anything that perhaps, or depression, even severe anxiety, that sort of thing. And where Joey and I have worked so well together is we've identified that, and we've thrown people either way, depending on what's going to be suitable for them. in that moment, and that multidisciplinary, that real holistic understanding of I'm not the only person here that can be of support or that's needed. And it often is also a GP. If people have been on medication, or if they need medication, and there are certainly cohorts of people that will, life is too brutal and it's almost too dangerous not to have them medicated. So we need to have a good working relationship with GPs, even with some psychiatrists, depending on. So depending on. But there's many people that I think are involved in working with people with these complex health conditions or presentations. So do you want to talk more about this slide, Joy?
Yeah, I think, what I'd like to do is actually throw it to the room, and this is your opportunity to unmute yourselves. And what do you, when you are in clinic, what are the things that you notice? What are the things that you think might tell you that someone has a trauma background?
I'll speak.
I really am going to wait for you to answer.
Tanya.
I think one of the things you can recognise, and it takes a while to, is a change in someone's voice. It can take them back, like when they're presenting with that flashback or an unsafe situation, especially if it was in childhood or early years. I've noticed you can notice a change in their voice and their way that they speak, so that they can use more younger person language, either that sort of 5-year-old, or if it's angsty, it can be more like a teenager. The points where they didn't have control and their identity was sort of shaped.
Wow, beautiful noticing.
Zena says use of trigger statements, volume can change, picking their fingers or clothing, looking away or back.
Yes.
I've noticed also that just the inability to relax or to seem relaxed at all. They can seem quite rigid as well when working through body work as well. The inability to, they must have total control during the session as well.
Yeah. There's that hypervigilance that, that people with trauma backgrounds are they're waiting for something to happen. Always. Yeah.
Hi, I'm Chloe. I'm a clinical nutritionist, and I'm actually seeing a client at the moment who does have severe trauma, and she also has really bad pain. So even in the consult, she's fidgety, she's in pain. I can see that she's not comfortable. So
yeah,
that's something very much associated, I think, with her trauma.
Yeah, totally. Hard to work with.
Zena says also older people often seem to say, sorry, we don't have time to deal with trauma. We had to build a bridge. Possibly.
Yeah.
Older generations are different in the way they are able to talk or not.
Yeah, absolutely. Well, I was traumatized as a child, and I'm fine. It's like, okay, well, that might be a matter of opinion. Yeah. And so how do that? And that's also, and how do I meet you? I might not agree with that client, but how do I meet them where they're at? So that's the shutdown that we had. I think certainly what you put into the room, and thank you very much for those of you who did, definitely noticing the overwhelm, the panicked, this disassociated, I'm actually not here. Right. Yeah. Psychological safety in your clinic, it's psychological safety is, it's just like this minefield. But one of the things, and I'm going to take you through a couple of exercises. When you're dealing with someone who has presented in any of these ways, just taking a moment to try and help them get back into their bodies, literally and sort of figuratively or psychologically, is always going to be useful. Thanks, Sue. Yeah, so the other thing is that quite often when there's a trauma response in the room, our nervous systems may get triggered. Okay, particularly because quite often as practitioners, one of our jobs is to co-regulate. So how does that happen? Particularly if you as the practitioner have been triggered by what your patient's doing. So first and foremost, your job is to try. Sorry, I've got sirens going past. They will. There we go. As a practitioner, your job first and foremost is to regulate yourself so that you can help your patient regulate. In the same way that how do you soothe a baby? Okay, what you're doing when you're working with somebody who has been triggered is ostensibly you're working with a baby. What would you do with a baby? You would probably cuddle them. You might pat them. You might drop your voice and speak low. You might hum or sing. I'm not suggesting that you pull out the lullabies for your traumatized patients, but who knows? But it is about how do I help this small being, if we're talking about the baby, how do I help this small being know that they are safe? And sorry, I didn't get your name, the first person who spoke, who said
Tanya.
that you, Tanya, thank you, who said that you noticed that their voices can change, and we get this very young, either sounding or the vocabulary changes, that's someone desperate for some co-regulation. And so what do we do? How do you ground yourself? Certainly for me, and given that during my sessions I'm always seated, the first thing that I will do is just bring my awareness to my feet on the floor. Okay. And it doesn't, remember that when your heart is beating faster because you've been triggered, or you're thinking, oh gosh, this person in front of me is struggling, it can feel as though things are taking too long. They're not. It is okay. Take a breath, push your feet into the floor. Okay, I'm grounded, I'm okay. And then you can go into how do I help this person who's sitting in front of me clearly in distress? The easiest, some of the easiest ways are to make them aware of themselves in the space. So could you just tap your foot on the ground for me? You don't have to give them a reason. It could be part of your assessment. I don't know. Maybe foot tapping is something that you need to do. Or could you just push your fingers together for me? Can you see me, Sue? I'm not familiar with Teams. Okay, so push your fingers together, and you're asking your clients to, because what that does is, first of all, it gives them a focus, so it brings their prefrontal cortex back online, and secondly, it brings them into their body. Okay. And you can, if this is a patient that you know, this is something like, oh, I noticed you seem to be, if they've ever said, look, this is stuff that triggers me. I noticed you seem to be a bit triggered. This is something that can help. Okay. That is still within your scope. Okay. It's a quick and easy thing to do. Name 5 things. Any 5 things that you can see in the room. Look for 4 blue things and name them. So those grounding exercises, those exercises that bring the prefrontal cortex back online, are things that will help people manage the trauma response. Beyond that, okay, that is it is time for you to say, this seems to be quite a big response, and I would suggest that you get some specialist help. And there are, I think the other thing to tell people when you are referring them on is to make quite sure that when they talk to whatever therapist they choose to go to, they ask them whether they are a practiced trauma therapist. Okay, there are certainly many psychotherapists, psychologists, counselors out there who actually do not know enough about trauma to be dealing, particularly not to be dealing with complex trauma. So so really important for you, if you're going to refer them on, about how they do that. It will also give them some containment. It might, if you're noticing that this is something that your practice seems to be attracting. Certainly, I think, Sue, you and I talked about, some people actually saying in their marketing that they do provide trauma-informed care.
Mm-hmm.
If that's something that you're saying, you will have people coming to you because you say that you know that you are trauma-informed. Trauma-informed does not mean that you are a trauma therapist. It does mean that you know how to deal with it in the first instance and who to refer on to after that.
Joy, can you speak to, you mentioned soothing a baby, and my training is not to touch a patient,
Right.
not to hug them, but would you
Sure.
say
Yes.
anything more about that?
Yes, absolutely. Good pickup, Sue. Yes, we definitely don't want to hug them. Particularly
Throw them over your
if
shoulder and
they
start
have,
patting their back.
well, yeah, and particularly if their trauma is because they're people who've experienced sexual assault or sexual violence. That's such a big no. Oh, just a quick note there on the language. You might have noticed that what I'm saying is people who have experienced sexual violence as opposed to survivors or victims. We are really trying to change this language. Language is really, really important, particularly in the treatment of trauma. And what happens is if you use the terms victim and survivor, what you're doing is you actually tie the patient to the experience. So what we're trying to do in trauma work is actually unhook them from the experience. And then every time we use that term, we define them by the experience. The other thing is that for some people in that space, to be called a survivor, it's a bit like being told that you're consistently strong. I don't know if that's happened for any of you, oh, you're so strong, you can get through anything. Now, if I'm not feeling particularly strong today, if I'm not feeling like a survivor because actually my intrusions have been going crazy and actually I'm convinced that I'm just a no good loser, telling me that I'm a survivor is actually just going to trigger me further. So, and it takes a while to get used to. And yes, it is a mouthful. But in all the research that has been done around languaging and trauma, people who have experienced, so all we're doing with that is by saying this is something amongst many things that you have experienced. Okay, and it gives you a bit of space to move. Sorry, that was a bit of a tangent. Right.
Back to how you won't touch a patient. What happens when
yes, you won't touch a patient. So what you can do is remember that, and this is something that we found out when we all started using online stuff. If you do this, okay, if you pat yourself, the person with you will experience it as though you are patting them. Okay, so giving yourself a good pat can help. Okay, getting them to do that thing with their fingers, getting them to feel their feet on the floor. Any of those things actually do the same thing as patting a baby. Okay, because what's happening in both cases, in the baby and in the traumatized person, is prefrontal cortex has taken a holiday. Okay, so the first thing we do is we're getting it back online. And we do that by actually bringing them back into their bodies.
And back into the present.
And back into the present. Here you are.
Mm.
I am here, you were there, you know. Yeah, what can you see? Can you see me? I am here with you, and I will not leave. You are okay. In this space, you are safe. Things like that. Yeah, lovely. Thanks, Tanya. You are safe. I just have to tell you, you are okay. I'm okay. We're here, and we're here together.
And so that's about the patient. Can we switch gears now and start to talk about as practitioners?
Absolutely, absolutely, Sue, because vicarious trauma, you know, everybody that I talk to says, yeah, I don't have it. I go, well, that's not true. Okay, what we know is that everybody who has been exposed to any kind of trauma narrative for anywhere between 6 and 9 months will be vicariously traumatized. Okay, so I, put my hand up. Absolutely, there it is. Does that mean that you have to stop practicing? Absolutely not. Does it mean that you have to take care of yourself? Absolutely. And what do we mean when we say, what does vicarious trauma look like? What vicarious trauma looks like is basically there are the same impacts as trauma, they're just to a lesser degree. So you might find that every now and then there is an intrusion. You have a thought that arrives unbidden and, is a bit, might be irritating or might take you by surprise. You might cry. You might feel your heart move beat a little bit faster. It's like, oh, that's that thing. There might be certain stories. There might be certain things that patients have told you. I know for me, there was one client that I had really, really early. It was in the first year that I was practicing. It was the most horrific story that I have ever heard. So over 30 years, I have never heard a story that is worse, and I'm not going to share it with you. And most of the time it's fine. And every now and then, and I mean, when I mean every now and then, it's like, I might not think about that for like 5 years. And then suddenly something will happen. And I'm hearing that story again. I was like, oh, it's still there. Okay. It's something that I will carry with me, and I'm okay with it. You know, I did a lot of work around it. What do we do with our vicarious trauma? First of all, you really need to watch yourself. If you start having bad dreams, if your sleep is disturbed, if you're not eating well, if you have intrusive thoughts, if you're finding that actually getting into your clinic is getting a little bit tricky, you know, if you're getting sort of 5 minutes late or 3 minutes late, or, you know, you always used to arrive half an hour before your first client and suddenly you're arriving 5 minutes, you know, what's happening to my behavior? That's most probably vicarious trauma. And what am I going to do about it? First and foremost, good supervision. Okay, please be supervised by somebody that you trust, somebody that you can go to and go, you know what, I think I really screwed up. Because if you can't tell your supervisor that you think you've made a big bad mistake, you probably shouldn't be with that supervisor, is the one thing I will tell you. Because we make mistakes. We need to know that we can talk them through with someone. Peer support, you know, which other gnats or nuts, or I'd love those, are you talking to? And, you know, and are you discussing ideas, and are you disagreeing with one another? And are there, you know, is there healthy discourse around what you're doing? Reflective practice, you know, am I thinking about what happened? And if you had a really tricky client, diffusing is incredibly important. If you've had a session today that has just unsettled you in any way, phone a friend, you know, phone one of your peers and go, I just need to diffuse. And the defusing questions, so if you talk, you know, try and set up a diffuse network. So, you know, I can call Sue and I go, I need to diffuse. And Sue knows she needs to ask me, what happened? What happened that's unsettled you? Okay, how is it impacting you is the second question. So what happened is the first question. How is it impacting you is the second question. And the third question is, what can you do to offset it? And it's really important that that gets asked. What are you going to do to offset this impact? Because ostensibly what that question does is it pushes you back into your agency. Remember that trauma is about our feeling of helplessness. Trauma is about, I have no agency here. So I want to be encouraged into a space that says, yeah, that sounds really awful. You know, I'm so sorry that happened. And what are you going to do about it? You know, and then you need to know what are the things that you do. And before we go to that slide, boundaries in consultations. So, you know, what we know is that it's really easy to be pulled into somebody's trauma narrative. And if you don't hold your boundaries, things will go wrong. I will say it that strongly. As soon as you start making your session go for much, much longer, okay? Bad news, guys, really bad news. Because what I know is that for many people, if they decide to disclose something, or if they decide to tell you something, the timing of that disclosure is really important. So I had a client once who, like, he would arrive 10 minutes before the end of the session every week. It's like, okay, so you're paying for 50 minutes and you're using 10 minutes. That's it. And over time, what I realized was that was all he could bear. What he had worked out subconsciously, that was his capacity. And as he got better at managing his mental health, as he moved into healing, he was able to come more and more, he was able to stomach a whole lot more until eventually, he could do the whole 50 minutes. And we landed up talking about it. He was with me for some time, but, he said, Joy, in retrospect, what I realized, he felt he'd always arrive, and be terribly apologetic, and I'm so sorry. And, he said, but what I realized was that I couldn't, like, I really thought I was trying to get there on time, but there was something in me that just knew that 10 minutes initially was all I could bear. So keeping your back. So if someone has timed their disclosure to 5 minutes before the end of their session, they've timed it so that they can get out of there in 5 minutes. Okay, I can tell you, you're going to tell me that the session's finished and I'm going to have to leave. That's the contract. When you change the contract and go, oh no, we'll just, I'm big-hearted Joy. I'm just going to keep really be here to support you and give you another 10 minutes. Actually, what you've done is you've just pushed me off the cliff. Okay, so boundaries really, really important. Sue, can we go to the next slide? Because in the next slide, we look at, okay, oh, right, no, we don't. Don't worry about that.
Go back.
Yeah. So what are you going to do to deal with your vicarious trauma? You're going to put good foundations for wellness into place. You're going to get good, I'm going to sound like one of you, I think. You're going to get good quality sleep. You're going to hydrate. You're going to watch your nutrition, particularly protein and vegetables. You're going to have a lot of laughter and fun. Okay, you really need to play is one of the most important things we can put into our lives, particularly if we are working in spaces where there are people who carry trauma. Play, okay, do something that has absolutely no reason at all. Okay, really exciting. I will get to you, Tanya, and connection with support of others. Okay. Absolutely. Tanya, how do you wrap up the session? What you say is, I am so sorry that that happened to you. Okay. I'm so sorry that that happened to you tells me that tells the client, the patient, that they are believed. Okay. We don't have any more time to talk about it today. Okay. You might think about taking this to a therapist. What I can do for you in our next session is we can look at any of the supports that actually are within your scope. So Sue, you would, if you were saying to somebody, we can look at, what would you be saying?
Oh, we can look. I mean, it might be that the prescription you're already giving is going to be supportive of their nervous system or whatever. But,
Right.
we can look at other techniques for, circadian rhythm regulation and all the macronutrients in particular we know are really crucial at this time. So that it's probably what's going to be in your prescription anyway that's going to start them off. But you can revisit that next time and say, find out how that went and where the difficulty was. And then you may have more. I mean, the mindfulness thing is always really helpful and the breath work. But again, Joy and I were talking about, when you're traumatized, someone telling you to breathe is like, you just want to wring their necks. It's like, well, of course I'm bloody well breathing. Thanks very much for telling me to breathe. That's maybe we need to have more time to explain what we mean by that. And you may have referral for someone who, like, here's a breath coach like Mim Beam, or you might have other referrals that you for other people, other modalities that could be helpful.
Right. I think that the most important thing, Tanya, is first of all that you let them know that their story is important. and you know that, you know, and gee, you know, wow, you disclosed it to me, and I will hold that gently. And you know, I need to make quite sure that you are safe to leave. So if you're very distressed, please sit in the waiting room or on the bench outside. And I need to finish now. Right, Suze, I think that's
yeah, I'll add in, I've sometimes given rescue remedy to people. Actually, I have no idea if that works or not. I believe it does, and I have seen it, and I think it's not going to hurt them. I can
Totally.
just give it to them in a glass of water, have them sit outside, I can put it in their drink bottle. And even if you don't know anything about bark flowers, you can go and buy rescue remedy and just give them a squirt. It can't hurt. And as I said, I have seen it do remarkable things.
And I was going to say, and that's within your scope and out of my
Definitely.
scope.
Yeah.
You know, so it's like, I mean, oh, if only.
I think bark flowers is such a over-the-counter, ubiquitous, and which is exactly how Dr. Bark intended it to be used by everybody for anything. Like it's meant to be. So it's not actually out of your scope, Joy. You could have it in your.
Oh,
It's just
great,
not something
thanks.
you've got too many tools in your toolkit anyway. So, but it's so that's what I'm saying. If you haven't trained in bark flowers, don't sit there and think, oh, I better go and do a course in that. You can,
Right.
but you don't have to.
Yeah. Okay. Thanks. um. Yeah. So professional scope. Sue, I think over to you.
Yeah, I think it's there's such a grey area, and because we're primary healthcare practitioners, we may be one of the first people to whom someone comes, and we might pick it up. And I think that speaks to the slide before about supervision. It's a given in counselling and psychotherapy and even in psychology that you have a supervisor, that you take all your cases to somebody. And it's not thought of in NAT or NUT or TCM. It may be, but it's not compulsory as it is. You can't practice without it if you're a psychotherapist. So even if you had a once off with somebody, or maybe you just had, it doesn't have to be a formal arrangement, but just to have someone to check in with, who can hold the space and have you go, this is what occurred, this is what happened, and I don't know what that means. Because often the first time you see an eating disorder, first time you see someone in deep trauma, you don't know what it is and you don't know what to do with it. But after you've reflected on that practice, maybe you've checked in with your friends, and I think a community of practice or a cohort that you know, love and trust is absolutely central to a clinical practice. I certainly have mine, for which I'm eternally grateful. And I think it's a really important part to go, this happened, and I'm not quite sure what the next piece is. What I will say is, if when in doubt, refer. And a referral is, I think, and Joy, you can speak to this, but I'm always making the referral about me, about the fact that I don't have the skills in order to be able to support where you are right now, but I know that it's incredibly important. And so what I'd like to do is give you the name of somebody that I think could be a good fit for you and work with you. Would that be okay? The referral is because my skill set is limited and where you are is so important. I want, that matters more to me. And I've often, and that's again where it's a really good from a business point of view to go and network and find psychotherapists, find counselors, find any allied health professional, whether it's a chiro or physio or anyone that you're working with that perhaps, and sometimes you might need 2 or 3 psychologists, psychotherapists, counselors, because they will be doing different things and have different focus. And so depending on the client that turns up to you as to where you might send them, if you're in ever any doubt about your scope of practice, you can ring your association and, you know, perhaps they will be able to guide you. I think that, yeah. Do you want to say something about referring people to, I mean, because the really important thing for me is when I'm referring someone to another therapist is that they don't feel like they're the problem.
Yeah.
Oh gosh, you've got that huge, great big trauma problem. Oh yes, quite, you better go here. It's about that I don't have the skill set for you.
Absolutely. It's like, you know, there are a whole lot of things that we can do together, and, you know, it may be useful, you know, and there are a whole lot of things that I don't do. You know, it's like me having, you know, eating disorder clients. I don't do nutrition, you know, so it's like we can do this here, but actually you need to be talking to somebody about food as well. So go and talk to somebody who knows what they're talking about. So Sue, absolutely, it's about my skill set and my professional scope. You know, it is about getting comfortable with actually that's out of my scope, that is out of my professional scope, and I don't want to overstep. I'm just having a look at disclosure. Do remember that if you're working with anybody who is under 18 and there is a disclosure of any kind of sexual assault or sexual harassment or sexual violence, it is there is mandatory reporting that goes around that. If they're over the age of 18, they have changed the law, so you don't have to report. But if they're under 18, it is a mandatory report.
Brilliant. And GPs at this stage are also someone that I refer to. I do have GPs that I do like and can trust to, you know, if I send them a patient, that they'll be given the care, and it will often be medication, but that's okay. I'm not adverse to that at this point. If it's something that's going to keep them safe at that point, emotionally safe, then I personally don't have any problem with medication in its place. I think that's part of my job as a naturopath is to work in with that, but that's a personal opinion. I won't go through the codes of conduct. I've got here who we are and what we are and who governs us, and forgive me if I've left somebody off. And I will obviously send you these notes, but I do suggest that you go and have a look at your code of conduct and read it. It will be very boring, but it is absolutely necessary, and it is not it's not a defense to say, oh, I wasn't sure, I didn't know. In a court of law, you have to know. There's a code of conduct for unregistered health practitioners that you also need to actually have displayed in your clinical practice as well as be aware of. So,
yeah,
do you have any thoughts?
There was a question about mandatory reporting. If you just Google mandatory reporting, the decision tree will come up and you can work your way through, you know, answers to the questions. And it is just, you know, it asks you a question and you say yes or no. If it's yes, you go to the next level, and it will tell you whether you have to report and where you should be reporting to.
Thank you. And I found this quote in one of the papers, one of the research papers I was looking at. No population is completely immune to a trauma and stress, but the burden is not shared equality. It's not shared equally. Gosh, I can't read. Until we name it, we cannot address it. And so I think it's a really important thing that we've covered tonight, is that trauma is something that we will come across in clinical practice, I have no doubt. And it is important to be able to name it, and that way you can support yourself, but also support the patient, and perhaps, you know, refer them on or redirect them. So that's, yeah, with the Himalayas in the background.
Too gorgeous.
So, Joy, do you want to, any final thoughts? Does anyone questions, queries, qualms, concerns?
I don't have any questions. Does anybody have any further questions for me? I think maybe the one thing I'd like to say is that you know, and Sue, your slides at the beginning is trauma is really not as uncommon as we think it is. Or as we might, well, I don't know, you might not think that it's uncommon. And that it's also not as scary as, you know, it doesn't have to be scary. It is just about knowing that when we meet trauma with compassion, we're probably, yeah, more equal. I'm thinking particularly when we're facing sort of emotional dysregulation. Quite often, you know, what I find is that when that's very much in my face, is like, actually, what am I looking at? Am I actually looking at complex trauma? And that kind of brings the that kind of brings the compassion back online, and then it's easier and not quite as scary to work with. Okay. Yeah.
Joy, Tanya's asked, is there a register for mental health professionals who've trained in trauma, as trauma specialists?
No, there isn't. They're one of the practices that I know of is Jackie Burke Psychology and Consulting. She's in Crow's Nest. She is like, she's got a PhD in trauma, and she works with a whole lot of trauma psychologists. Yeah,
Has PACFA got anything on their website that's you could look up therapists and
yeah, you could try, Sue. I don't think, I think that Jackie's most probably one of the few people who is you know, she's very zealous about trauma specialists. And so they may, or PACFA, I think you're most probably going to find the APS is most probably, so Australian Psychological Society is most, they are probably, the psychologists are probably more likely to say that they are trauma informed than anyone else.
Okay. Just trying to Google them. Psychological Society. Okay. Psychology.org.au.
Australian Psychological Society, yeah.
Is that it? I think. Anyway, I'll and I might include I will be sending a recording at some point in the very near future when I get time to edit. And I will perhaps include a few emails or, you know, websites, Joy, to that.
Right, thanks. I think the other thing is just thinking about, you know, obviously we've talked about trauma, and this whole thing has been about trauma, and we, you know, but it is not necessary to, if someone is distressed, it doesn't matter whether you think they are, whether you think it's a trauma response or not. The only thing that matters is that you find a way to be present with them in the room. Okay, it might be trauma, it might be something else. It doesn't matter. The what, or the actual diagnosis doesn't matter. What I know is people are in pain everywhere, and whatever we call it, as practitioners, the most useful thing we can do is just to be there.
And I've got a reference list, just by the way. And the other thing that I thought would be remiss of us for not putting out is the contacts for you and all your patients. Lifeline, you always know, 13 11 14. There's some suicide callback. There's kids helpline, Beyond Blue, Beyond Blue and Beyond Blue Knot, and then 1-800 Respect. So, and there are far more, obviously, and there are some that are specific for each state, which I didn't include because I had didn't want to be New South Wales centric. So if anything's come up for you tonight, please take great care of yourself, and you may avail yourself of any of those particular numbers on the screen. But yes, I would like to thank my dear friend Joy. That was remarkable. You always are.
Thank you, Sue.
And I hope that was of use. I know it is. I know it was. And it may be that there are layers to this, and it will keep maybe keep percolating for you. And I hope that one day it will be supportive for you in the room and for the people that you are seeing. And I want to say thank you and namaste.
Yes.
That's the beautiful Himalayas, and many of you will know Lakshmi, who we partner with over there, who does a lot of lecturing and teaching and support for young Nepali women, keeping them out of the sex trade. So go Lakshmi, and we are a huge supporter of her. We gave her $10,000 last year from the Nepal Social Impact Association to try and support furthering education of young Nepali women. So the work we do in Nepal is, I'm quite proud of it. I think it's really targeted and it's very effective. Tonight we've raised around $1,500, so I'm very grateful for all of you attending, as well as my dear friend Joy giving up her Wednesday evening. So thank you all.
Thank you, everybody. It's been lovely to spend the evening with you.
And I'll look forward. Stay tuned. I'll have more webinars coming up next semester.
Thanks, Sue. Thanks, Joy. Bye, everyone.
Pleasure
Thanks.
all.
Bye,
Thank
Tanya.
you.